Greetings, and welcome to this webcast of the Methodist DeBakey Cardiovascular Journal. As many of you know, the journal publishes 4 times a year and does reviews in very specific topics as a way of updating the education for all of us cardiologists. And we pick up certain very important topics, and more or less every 5 years we repeat them because of the new developments that occur in the field. And the current issue is in one of those topics, coronary artery disease, a topic that we are all extremely familiar with as general cardiologists as well as surgeons and interventional cardiologists. So I'm very much indebted to our two guest editors today. They have done a marvelous job. Dr. Nadine Faza. She is the Associate Director of our fellowship program. She is a very well established cardiologist. She has expertise in structural heart disease, valvular heart disease, women's issues, and coronary artery disease. And she is going to emphasize, she's going to work in most of the general topics in coronary disease that the journal emphasizes. Joe Aoun, is that correct? Aoun?
Perfect.
Okay. Joe is one of the esteemed members of our interventional team with expertise in all kinds of weird interventions in structural heart disease, coronary disease, you name it. And he focused in the part of the journal that deal with a lot of new developments in the interventional field, some of the actually very technical issues, things that are going to be attractive to the interventional cardiologists who read the journal. So without any more delay, I put it in the hands of our two esteemed guest editors. I think, Nadim, you're going to start?
Yes, thank you so much, Dr. Quinones, for this kind introduction and for the invitation to edit this important issue of the journal, for your support. And it's been an honor working with you, Dr. Aoun, on this issue, on this topic. It's our honor and pleasure to introduce Dr. Attila Fair, who is an assistant professor of cardiovascular medicine and radiology and biomedical imaging at Yale University School of Medicine. And we'll be discussing his review article on CAD at the intersection of cardiology and rheumatology, with focus on the role of cardiovascular imaging. Dr. Fair, welcome to our webcast.
Welcome. Thank you very much for the kind introduction. And it's really my pleasure to be here. And first, I would like to thank the organizers for giving me the opportunity to write this review and to present this review and discuss this important topic about coronary artery disease in rheumatologic condition.
This has really been a hot topic recently. There's more studies addressing this area of CAD. And I want to start by asking you, why do patients with autoimmune rheumatological diseases face a higher risk of atherosclerosis even after accounting for all the traditional risk factors?
I think what is interesting that is not very well known for us cardiologists, that we think of autoimmune disease as a rare disease. And this is partially true because individually all these diseases are quite rare, but when you put them together, it's actually the third most common disease group in the United States. Only more frequently found is cardiovascular disease and then cancer. So it's the third disease type. And when it comes to cardiovascular risk, we see, and this paper nicely demonstrated, that any kind of autoimmune disease increases the risk of cardiovascular death, and when you or cardiovascular risk. And when it comes to the different diseases, lupus, systemic sclerosis, Addison's disease, are associated with even higher risk. And the particularly high risk ones are the ones who have more than one autoimmune disease, and that's also not as much appreciated. When it comes to what is that risk, what is that risk coming from? I don't think it's quite well defined, but there are certain factors that can play a role. For example, traditional risk like hypertension, diabetes, obesity, smoking is more common in these patients. There can be associated cardiac involvement specifically related to the autoimmune disease. Systemic inflammation definitely plays a role, and more evidence is coming out that the inflammation, the residual inflammatory risk, plays a huge role in cardiovascular risk. side effects of steroids. We all know how steroids are very harmful, and it can increase cardiovascular risk. And another thing is sedentary lifestyle because of arthritis or pain or depression. So it's really a multifactorial thing.
Thank you so much. And how do you think advanced imaging techniques like PET, CT, and CMR can enhance the detection and the risk stratification of coronary heart disease in this high-risk population?
Well, so this is what we really articulated in this review, how we can use cardiovascular imaging. Cardiovascular imaging in the last decade or so underwent huge developments. Were really big breakthroughs where we can estimate risk and we can diagnose coronary artery disease even without invasive intervention. So when it comes to looking at risk, we can look at the anatomy, or you can do functional imaging, which we talk about in this review. Anatomical imaging, obviously coronary CTA, again, very huge advances with lowering radiation dose and getting down to the 0.2 millimeter resolution with the new photo counting technology. But what it's quite important to note, it's that this is not only the epicardial disease. A lot else goes beyond the epicardial vessels. When we go down to this sub 500 micrometer resolution, there is the microcirculation, and the microcirculation is where most of the resistance lies. This is where most of the intramyocardial blood volume lies, and it's many times it's the determinant of symptoms in these patients. And these autoimmune disease population is particularly more susceptible for coronary microvascular disease or vasospasm. And when it comes to non-invasive imaging, really the more frequent use of PET, myocardial blood flow quantification, and also quantitative stress perfusion MRI can really quantify myocardial blood flow, and a reduced flow reserve in the presence of normal perfusion is really a non-invasive diagnosis of coronary microvascular disease. On the other hand, very exciting things are happening about plaque composition with coronary CTA. We can see beyond the vascular lumen. It's almost like an intravascular ultrasound, but an IVUS, but we can do this non-invasively. And also another exciting topic is the perivascular adipose tissue, which is now we realize that it can present cytokines to affect endothelial function and the vascular function, but also it's a two-way communication. So the endothelium, dysfunctional endothelium, also affects the phenotype of the adipocytes, and it can be a marker of high risk. And molecular imaging I think is the future, with more and more new radio tracers being developed.
Fascinating. The role
so
of
one of the signs that a particular field in medicine is getting a seat at the table is when young people training want to go into it. And actually one of our best residents that we were trying to keep here decided that she wanted to do a fellowship in a place that had a strong rheumatologic partnership, because she wanted to specialize specifically on that. So I think that's a good sign that this is a very important topic, no question about it. Now, in terms of treatment, you have somebody, let's say, with rheumatoid arthritis, and you're trying to do cardiovascular prevention and whatnot. Do we still do the traditional things, or is there anything unique that you have to then emphasize more in that particular patient that you would in your regular patient that has perhaps diabetes, hypertension, and high cholesterol and whatnot?
I think this is an excellent question. Many times, so I'm a cardiovascular imager. I do multimodality imaging, but at the same time, I also have a cardiorheumatology clinic. So I do see these patients who have rheumatologic problems and with cardiovascular disease. And when I see them, the problem I quite often face with is I try to put them on lipid-lowering therapies, specifically statins, and they already have aches and pains all over their bodies. So they need a lot of in-depth conversation and patient-tailored decision-making. And many times I turn to imaging. So I pull up their chest CT that was done for totally different reasons, for example, for interstitial lung disease, and I show them the images on the CT, and I convince them, and patients know what they're looking at. I tell them that, look at your CAT scan, and these are your heart vessels, and if they look like bones, they understand that that's not good. So in this way, many times I'm able to convince them to start statin therapy. what your question was really about is whether there are any specific therapies what we could use. I think research is ongoing, and we still have to see whether tailored therapies to these autoimmune diseases can affect cardiovascular risk. One exciting story is the story of colchicine, which is a cheap medication where you can knock down inflammation. So specifically patients who have a CRP higher than 2, if you give either secondary or primary prevention colchicine, and you're able to control that inflammation, that it can reduce future risk. So many times I turn to colchicine in this patient population.
Good point. Great. Thank you.
Perfect. One last question, or if we have time for more questions, that's even better. How is the working relationship with cardiologists and rheumatologists in terms of managing these patients? Are you ordering the biomarkers? Are you making sure that the inflammation is controlled from the rheumatological standpoint? Can you please elaborate on that kind of collaboration between the two specialties?
Yes, this is really important. And we try to, I think the whole cardiorheumatology is designed to work as a group together. So, for example, if someone has myocarditis related to their autoimmune disease, I'm not the one who will prescribe all the immunosuppressants, but we have a live conversation with the rheumatologist, and together we tailor the therapy. I will follow the imaging results and biomarkers, but we're in constant talk about the management of the patient. And this is true for the primary prevention. Usually, when it comes to describing lipid-lowering therapy, usually the patient comes to see me, but we're always in contact with each other to help. I think the goal is to help the patient to prevent events and to make them healthier.
Right. Very good.
Okay.
Joe?
Yeah. So we're going to go to our second speaker. Basically, we have Dr. Alicia Kainat. She's a clinical assistant professor at University of Pittsburgh Medical Center, and her article is about population-level gaps in CAD, a focused review. So first, just for the main question that we want to ask is about disparities in risks and outcomes. So what are the major racial and ethnic differences in CAD prevalence, risk factors, and post-MI outcomes? And what role do social determinants of health play?
Thank you so much, first of all, for having me. And I appreciate the opportunity to participate. And I also appreciate Dr. Saeed, who was my mentor at UPMC, to let me participate here. So when Dr. Saeed told me to write this review, this is something that is actually close to heart because I am interested in this. I always look at the minority populations. I look at how women have different risk, and unfortunately, there's still, in 21st century, there are risks that exist. Unfortunately, the racial and ethnic minorities face a disproportionate burden for CAD. We all know that Black populations, Black adult patients have higher risk of comorbidities, including hypertension, CKD. They do also have shorter survival post-MI, as studies have shown recently. We know that the South Asian population are more prone to premature CAD, and all the risk assessment scoring tools that we have, they actually under-assess the risk in South Asian population. They also carry a higher risk of diabetes. These are all the traditional risk factors that have differences. We also know that Hispanic patients have a higher risk of diabetes and obesity as well. Now, when we look at these biological or traditional risk factors, they definitely vary, but there are certain social determinants that have been coming to light that, a lot of different studies recently have been shedding light that have been telling us that how socioeconomic disadvantage, like such as the neighborhood disadvantage index that have come into light recently, are so disproportionately effective of Black and Hispanic populations. Simple barriers to healthcare, such as barrier to medications, healthy food, even just like having a pharmacy in your neighborhood, like lack of having a pharmacy in your neighborhood affects these risks. And all in all, in this region age, we do have papers suggesting that structural racism still exists, which basically leads to or contributes in part to these increased earlier events and worse outcomes in these minorities.
Well, thank you. This is a great answer. You actually sort of summarized the big portion of the paper in a way. So in practice, in your clinical practice, you do some risk assessments which are not generalizable to specific populations. And let's say you have a specific population that is not included in your risks and these risk score. So what do you do in clinical practice? Do you sort of sometimes say, I want to overtreat just because of that, or how do you approach that?
So I'm basically an internist, and all of my PCP, or you can say the work, I do not necessarily inflate the risk. We just go by the guidelines. And if I do have, in our clinic, if there is some of the patient populations that I am well aware that they're not going to be able to follow up, they have certain barriers such as they have unstable housing, or they had acute MI, they have a stent, I really need to make sure that they're going to be on DAP. We do have an in-house social worker that we try to touch base and try to come over some of the risk factors, like basically just providing them. So we ended up providing one of these patients like a bus ticket to get to the clinic. So it's just the simple things, trying to understand the socioeconomic barriers when you even just chat with the patient and try to tackle them. And it doesn't take a lot. It's just, I think, the trust of the patient that you end up gaining and end up delivering the same amount of care that you would. I know there's an extra step that you have to do. You have to involve your caseworker. You might need to make an extra phone call, but I think that's something that you need to recognize early and just try to make sure that you incorporate in the care that you're providing that very patient who's a minority.
Okay. And in terms of like inequities, where do you think it's happening the biggest amount? Is it at the time of diagnosis and therapy? At what stage? Is it in interventions? And what stage do you think it's most affected?
Yeah, it's very interesting that looking at the, when we were just reviewing all the studies, it's very interesting that it honestly begins with the moment of symptom recognition. A lot of these minorities, especially Hispanic population, maybe it's a cultural barrier or maybe it's a language barrier. Their symptom recognition is actually way delayed than when you compare with non-Hispanic white population. The moment they enter the ED, they have delay in care, like the door to balloon time for the Black population, for Hispanic population. It's even the first medical contact, and there has been certain risk factors that have been identified, such as language barrier, such as patients not being able to lack of medical education on their part. But it actually begins the moment of symptom recognition, the moment they arrive to ED, getting first medical contact. It is well known, still in the recent in his data that the Black patients still have a longer door to balloon time for a PCI compared to non-Hispanic whites. It's also interesting that even after a secondary event, the referral and even the participation in cardiac rehab has a lot of disparities, especially when we look at the Black population. They have the lowest participation of referral and participation in this cardiac rehab. So I feel like even if we count most of these disparities, even if we account for other risk factors, let's say, for other comorbidities, these disparities exist, which kind of speak somewhat of the systemic barriers and the bias that we still have in our practice.
So I have to say that I agree with everything you said, but I'm also, in my own practice, very frustrated. We have a clinic that we go to once a month. It's in an underserved community, and I go with a fellow once a month to see patients. It's a wonderful experience for the fellows. They love it. And we see a lot of these type of patients in an underserved community. Many of them are Hispanics. And it's really very tough. I mean, there is no other way to say it. First of all, we all humans have priorities. We all have it. Their priorities is to survive. Their priority is to put money on the table for their kids. So they work. All these people we see, they are all working. And they're maids, they're in the restaurant, in the kitchen, and for them, health becomes a secondary issue. And this is a reality. And we write great papers about it and we keep emphasizing it, but when you get down to the nitty-gritty, It's a very hard thing to handle. And I think we need some sort of team effort with support, of course. Once you engage them, they do get engaged. I have a lot of patients that are taking their statin, their A1C used to be 10, now it's 7.5. So you can engage them, but to get started in the process can be very, very tough. So any words of wisdom from you?
I guess, when we were thinking about what we need to do, I don't think it's an individual problem like you mentioned, Dr. Gomez. Like, I think it has to be a structural level change. Like, we are integrating routine screening of social determinants of health. I know part of it we do when we come to an admission process, but like doing it at a PCP level, like what social determinants of health, that we need to focus on so that we can ensure an equitable pathway for timely revascularization, timely rehab, and also we need to incorporate some sort of, structure or hospital level or in barriers to encounter the financial challenges that we deal with. This is obviously going to be a very challenging part, especially with ongoing changes to the system. But I think as part of the bigger picture, it's just to have a culturally competent training staff, make sure that we have training of our staff to, encourage that, there is an implicit bias and, we provide cultural competence. We develop a culturally tailored community outreach. And I also feel like that improving the participation or diversifying the population that we have for trials, participants and researchers would also help identify most of these barriers and kind of understand where the pathophysiology is coming from for these disparities.
Do we know, and I'm asking everybody, because do we know if there is any data from countries that have a medical system with a lot more accessibility, for example, the British, if having more accessible care improves this particular group of patients? Do we not have any data to suggest that if we look at other countries that have more access to medical care, to this subgroup of people who exist everywhere, not just in the US, do they have better outcomes? Or is it still a problem over there too? I'm asking, I honestly don't know the answer.
Yeah, I personally am not aware of data, but I can tell you from understanding the topic well in a way because of our background.
Right.
Because I did part of my training in the beginning back home and then moved, and my parents are in a different country, and you can understand by talking with different people how the system works. It's once you have a little bit of accessibility from an economical perspective, people would start seek more medical care. But on the other hand, there's the culture barrier where the people actually might think that, hey, if I go to seek medical care, I might think that I'm weak now, I cannot function, I would stop working.
So you're dealing with the educational part of the whole
you have
thing.
both, both as main issues, and I think those are separate.
It still remains a challenge no matter where we are. Yeah, all right. Thank you very much. That was a wonderful article.
Thank you so much, I appreciate it.
All right, thank you so much, and it's my pleasure to introduce our next author, Dr. Purvi Parwani, Associate Professor of Medicine and Radiology at Loma Linda University, who's joining us to discuss the most recent guidelines on the preoperative assessment of patients prior to non-cardiac surgery. We've been waiting for this update. There's a lot to discuss, so we're very excited to have you with us today.
Thank you so much, Dr. Feza, and thank you to your entire team. Really excited to be here in midst of a busy day and share my insight on the topic. I was fortunate to be on the guidelines committee for the pre-op guidelines, and it was a taxing process, but I think we're very happy with the guidelines that we put out. So happy to share my insight.
So the answer is very easy, right? We do an echo in everybody.
Actually,
at least that's what our surgeons do here.
I thought it's a CAD.
Nadine and I, we have our job secured. I'm the Echo director here, and you are absolutely right. In any cardiovascular patients with cardiovascular symptoms, and respect the echo is actually class 1 guideline, class 1 level of evidence, right? So echo gives you a lot of information. So echo is easy. It's when we get to the stress test, the nitty-gritty of what we need to do. That's what we are here to discuss, because I think that's the thing that's being misused. Overall, if we see in United States, there are around 14 to 20 million procedures that we do every single year. I think orthopedic surgery is the major chunk of it. Around 50% of the cases are orthopedic surgery. And unfortunately, a lot of patients that we see do have risk factors, but how do we safely put them on table, and what is our role as a cardiologist? That's what we are here to discuss.
Perfect. Yeah, we always get these pre-operative consults, clearance, and then stress versus no stress, and functional capacity. So let's tackle some of these important points that were addressed by the new guidelines. So how do clinical risk factors, functional capacity, and frailty assessments compare in predicting pre-operative outcomes to the routine ischemia testing that we're all used to?
No, that's an excellent question. And I think guidelines speak at length about, just being a clinician. So number one thing is that put your clinician hat on and see what you can give that patient in that clinic visit, right? So you have to evaluate the patient fully, try to assess their, risk factor. When we were writing these guidelines, we realized that pre-op might be the first time some patients are visiting their doctors. So we want to take that opportunity, and we want to give these patients all the prevention that we can, because we know overall we might be losing these patients afterwards. So I think that clinic visit, the pre-op clinic visit, whether it is with primary care or the cardiologist, it's very important. We also realize there is wealth of data that a frail patient, regardless of age, regardless of anything else that you can do, frailty really adds a layer into this risk assessment. So a frail patient has a higher mortality compared to the patient that is not frail, even at lower age group, like in less than 50 years old. So we realize that frailty assessment for all the elderly patient is absolutely necessary, but also the patients that appear frail because of their comorbidities, we have to do it. And what we recommend as a very high level recommendation in the guidelines is that if your patient appears very frail, actually, if it is an elective surgery, you give them prehab. Or if they're so frail and they're elderly and you don't think that they are not going to make it, and then you basically address the code of status. So either ways, you give this patient either the prehab or assess the code of status overall and see what you can do for that patient. So that's number two. Number three is the risk scores, right? So we all use RCRI very extensively and widely in United States. And we realize that this risk stratification, just by using the clinical criteria, can add a lot of value. The unfortunate part is when you add all of these things, your clinical assessment, the RCRI score, frailty assessment, and add stress testing, that doesn't add anything. So if we look at the randomized control trial, even in high-risk patient, like CARF study that was done on patients with vascular disease, these are high-risk patients that we deal with in cardiology all the time. Even in that trial, doing revascularization wasn't useful. Meaningly, we are doing the stress test to find the patients that have atherosclerotic cardiovascular disease that is significant, and then we are putting them for revascularization. But unfortunately, the revascularization doesn't help. Now, of course, I have to mention the major exclusion, which was your left main disease, your severe aortic stenosis, so those are not the patients we are speaking about. We are just speaking about the patients that are at risk of getting coronary artery disease and that have higher risk based on that RCRI score. So I think that between 2014 guidelines and now the 2024 guidelines, that's the major difference that you will see. That we are not advising stress testing routinely, and that evidence level has actually gone down in the algorithm. And once even for the patients that you choose to do stress tests to do further evaluation, you really need to involve that multidisciplinary team to see what difference are you going to make, going to give this patient. So that's in nutshell, what we put out in this article. And of course, your viewers have to go read the article to get more.
I'm pretty sure they're very excited. So a quick question regarding frailty. In practice, in clinical practice, what do you think, how can we do it? Is it the eyeball test? Is it more hand grip? How do you do it in your clinical practice?
No, that's an excellent, question, right? So I think the guidelines, remember, this was put out for all the primary care, your anesthesia, colleagues, your all of us cardiologists. And I'm not sure in your hospital, for the structural patients. I know Nadine deals with a lot of structural patients. I'm not sure if you guys have already dealt with this issue, but like in our hospital, we already have a template that we follow, and we follow the frailty assessment tools, right? And I think we just have to kind of change our mindset and kind of bring it back on these patients as well. So there are a lot of frailty assessment tool. The fried phenotype, that's the well-known one. I'm sure you all have seen. So the guidelines go into depth of it. But I think really, what I did after these guidelines, got released was I reached out to the anesthesia colleagues in our hospital. I gave grand rounds to surgical and anesthesia team, and really bringing that team together. This is a team sport, right? Like, you're not going to deal with these patients alone. So I really think that every single hospital needs to establish a structure where there is a very smooth patient flow, and you really selectively see these patients that really need a cardiologist. Otherwise, they get cleared by primary care and anesthesia. And there has to be, assessment tools that are determined so that before even you see your patient in cardiology clinic for a very specific question, anesthesia and primary care have already done these for you, whether it is RCRI score, fried score, frailty score. Even for the functional assessment, there is a very good literature from Duke actually that shows that by doing a quantitative functional assessment known as DASI score, that actually adds more value than just asking the patient, are you able to do a couple flight of stair, can you dance with your partner, all those questions that we are used to dancing. So I think I really feel the need of that multidisciplinary team coming together for this particular patient group, because there are a lot of patients that we deal with in any medical center in United States.
Yeah, I think this is a very, very important topic, and we clearly are overdoing a lot of procedures that we shouldn't do. In that regard, I am happy to report that at the age of 79, I had my knee replaced. I cleared myself without any echoes or stress testing, and I did just fine.
That's great.
Did you get a troponin or a BNP?
I did not get a troponin or a BNP.
I saw him climb a stair on one foot.
Oh, yeah. More than 4 meters.
Hey, I'm not sure with all that Houston, steak you all have, but that's okay. That's just my perception from California.
All right. So when I was a fellow, none of you guys had been born yet. Patients came in with a heart attack, and they went into cardiogenic shock, and all we did was give them some inotropic agent and pray. And survival was dismal. And now we move 4 to 5 decades later, and we're still dealing with the same problem. Cardiogenic shock is a bad disease, and patients, it's hard to get a group that survive. Now we have the balloon, the intra-aortic balloon. Now we have the Impella devices. We have the ECMO. So we have all these tools that are phenomenal for keeping somebody alive for several days. But at the end of the day, results are still tough. And there's been a lot of clinical trials with a little bit of controversial findings. So Joe, you wrote this wonderful article. So why don't you give us a little bit of a summary?
Yeah.
You have these trials. They have had different results. How do you put it all together and get some sort of perspective yourself when you're with a patient deciding what to do next? Tell the family to call the preacher, or do we go aggressively and do all these things? What kind of survival you're looking after, expectations, and so on. It's a very tough group of patients.
Well, thank you for this actually great summary in a way how to put it together. So cardiogenic shock is a deadly disease. And looking back, as you said, 20, 30 years ago until now, there has been some advances, but there hasn't been much changing of like the outcomes. There's a little bit of improvement, but we haven't seen a lot of outcome improvement. So about 50% of those patients, they die almost no matter what you do. And of course, depending on the studies and trials, you'll see 40% to 80% in terms of mortality. At the same time, we know that, once you have an acute heart attack and the system starts to fail, you have a decreased cardiac output, multi-organ failure. At that time, it's more of a vicious cycle. So our goal is from this paper is to try to identify, is there any time frame where you can stop that? And in terms of like trials, has been a lot of heterogeneity based on depending on the devices and comparing those devices, but there hasn't been a significant change in terms of outcomes. So if you ask me what is the most important time frame to treat this disease is as early as possible. So early detection is the most important. And saying this, we classify cardiogenic shock from A to E based on the SCAI definition. We want to be as quick as possible, which is the B, where the beginning starts. And typically those definitions are actually when you have a low blood pressure, maybe it's a little bit soft compared to their baseline, but also if you have an increase in lactic acid. The only issue is if you have a heart attack, you're not going to be waiting for the lactic acid to do it, right? So in our clinical practice, we rely heavily on hemodynamics at that time on the table, where you can float a swan within 3 to 5 minutes and get some hemodynamics. And this is where we should start there.
So what numbers are the ones that make you feel that you're in an early stage of cardiogenic shock? I mean, we better get moving.
100%. So first, the first thing that happens is actually increased filling pressures. That's as early as possible. But once you have that, depending on the heart attack that you have, let's say you have a proximal LAD, somebody with chronic heart failure that you know that their EF is already borderline, and then they have an EF, they have an acute anterior MI, honestly, probably without even doing anything, you're going to know that they're going to be in shock.
Right.
And it's just the clinical scenario that tells you.
Right.
And that recognition is going to tell you, hey, let me get access, let me think about putting a temporary mechanical support at that time. Those are very important. On the other hand, of course, when you put a swan, you have a cardiac index that is low. You have a wedge that is high. And then we calculate sometimes what we call PAPI, which is basically the pulmonary pressure difference divided by the RA, where you can get a sense whether the RV is not doing well. Maybe you need support for the RV at that point in time. And there are certain cutoffs that we use, about 0.9 or so, and we calculate sort of the cardiac power output. There are certain things that we rely on, but most importantly is clinical decision making.
So you have a lot of stuff you do, a lot of stress you put on the patient, the family, and of course the cost of care. What parameters do you use to decide it's time to stop?
Very good question.
Because you can squeeze this lemon until you have the last drop, and you have $1.5 million in the of expenses, and still at the end,
well, that goes back as well to the topic that Purvi was talking about, frailty, right? I mean, if you have someone who's already very frail, at baseline, they're not functioning well, they need so much assistance, they have a big, huge MI, you have to have the conversations. When someone at baseline is already really functioning well, I personally try to have the conversation that maybe we should do as much as we can as early as possible to try to get them there.
So in my simple view of looking at this, I categorize, in acute MI, I categorize cardiogenic shock into two main groups. One is caused by some acute mechanical failure, like, for example, severe MR or a VSD, or something that potentially could be helped. And the other group is just basically bad muscle. So I'm assuming that if you're in a center with expertise in surgery and interventional, the group that has mechanical issues like MR or VSD do have a little bit of a better edge, because you can hopefully intervene there, and if they still have enough muscle, support them and get them well. The question is when they just simply have bad muscle. I mean, at some point in time, when do you decide either you go to an, because you cannot, right now we have still not found how to regenerate that muscle. So
Yeah.
to me, that is the group that I consider it a nightmare. Because you intervene and put all these mechanical devices, but you're fighting a battle that might not be winnable. How do you guys work with that? Because night and day you guys are doing this. I mean, I'm sure this keeps you awake sometimes when you have to come in and do all these things.
100%. So, I mean, acutely you have to make a quick decision, and unfortunately you do not have so much time to get so much history to make the best decision ever. But based on what you have in an acute MI setting, and you want to get door-to-balloon time, you want to put an MCS if really needed, you're going to make some decisions at that point in time, whether to put a balloon pump, an Impella, ECMO, if needed, based on their need in terms of hemodynamics. But on the other hand, once you do that, you'll have more time to reflect how long are we going to process and what are we going to do with that, right? Because you're going to fix the vessel, hopefully, and get a really good result. But there was a recent publication that actually showed that significant improvement in SCAI stage within 24 hours will get you a better mortality. So in other words, you did the acute thing. You managed really well, hemodynamics, you're having SWAN, you put them in the ICU, and then within 24 hours, their SCAI shock definition dropped, let's say, from E to B or E to C. Those patients have double survival compared to the patients that have not improved within 24 hours.
Good.
So you start having more conversations about, should we stop here? Should we continue doing this care? And it's always challenging. There's never a really straightforward answer.
I'm grateful that there are young people like you who take care of those patients, just in case in the future.
I always get them an echo.
You have to. I have a question, because nowadays we have so many choices for circulatory support. So how do you decide which device you're going to use in which patient? How do you make that determination, especially in light of the recent trials that were more favorable towards some versus others?
100%. So it's a very valid question, and it's very important. And as an interventionalist, one, you have to think about it. Part of it is mechanical, part of it is non-mechanical. In a way, mechanical, can my device fit? So if I have vascular disease, severe PAD, I mean, I cannot put a 14 French, right? So I cannot use an Impella. It's that simple. On the other hand, I want to think about how much support am I giving my patient. So an Impella can get you up to 3, 5, 4 liters per minute, versus a balloon pump, it's going to give you about 0.5 to 1 liter per minute. So if I need a lot of support, I'm going to just jump to an Impella and not put a balloon pump. That's something to think about. On the other hand, the ECMO, for example, we sort of just put it predominantly when you have really BIV failure, you have severe respiratory failure, maybe a patient had a cardiac arrest. Those situations, you really need a lot of support. But saying this, VA ECMO is going to increase your afterload, so think about LV unloading at the same time by using an Impella. And the most important thing is data, right? I mean, the most recent trial of the danger shock that was published in I think 2024 now has shown that you have better improvements in outcomes with Impella in those patients, assuming that you put it in time as early as possible, and as based on the fact that you're not putting it in patients who are too far gone. And that comes again in some of the VA ECMO studies where, for example, the ECLS shock, they included patients, some of them, they actually were too far gone where they had not great mental status anymore. And, you have really good hemodynamics, they improve, but then just don't make it.
They don't make it?
Yeah.
All right, well, work in progress. In the next 5 years from now, in the next review of the topic, we'll have some improvement.
Yeah, Impella, I will just put a micro Impella and that.
All right.
Thank you for this review.
All right, I think you're going to introduce Dr. Patel?
Yes. So Dr. Akash Patel, thank you for being here. He's one of the chief cardiology fellows at the University of California, Irvine. He wrote this paper under the mentorship of Dr. Antonio Frangille, who's an interventional cardiologist and a structuralist there. So the paper was entitled Drug-Coated Balloon for Coronary Interventions, which is a very hot topic. Now, we know that DCBs are being used so much in Europe. and we still have this delay in the United States. The main reason is, we have to get the FDA approvals, and we don't have a lot of, trials in the US that actually that led to this approval quickly. Saying this, I just want to say, how do you think about drug-coated balloons compared to DES in the treatment of ISR? And what are the advantages? Does leave nothing behind versus leave some lesions? So what are your thoughts about that?
Yeah, it's a good question. Just want to say thank you guys for the opportunity. It's been a pleasure writing this review, and thank you to you guys and Dr. Pranjay for the opportunity. In terms of looking at drug-eluting stents versus drug-coated balloons as a head-to-head comparison, especially you have to look at it in different indications. So if we're looking at drug-coated balloons in the setting of in-stent restenosis, which is what we have FDA approval for, drug-coated balloons versus drug-eluting stents, there's really a non-inferiority, which is for the last decade, it's really been sort of the treatment interest, is looking, is this safe? Is this effective? Is this something that can compare to drug-eluting stents? Not necessarily looking, is it superior? So that's something that really we need to understand. And for this, really, drug-coated balloons are non-inferior to drug-eluting stents. You have to really understand the mechanism of in-stent restenosis. So if you look at early in-stent restenosis, that's usually done by intimal hyperplasia. And then when you look at late stent restenosis, it's usually done by neoatherosclerosis, so new atherosclerotic lesions forming around the stent. So there's thoughts that when you have neointimal hyperplasia or early in-stent restenosis, putting in another drug-eluting stent or even a bare metal stent will worsen the hyperplasia and lead to worsening ISR. So in these, the idea is that putting a drug-coated balloon, making adequate contact, allowing this drug to really infiltrate the intima and the adventitia to really reduce the hyperplasia that's around that existing stent, is the whole idea of using a drug-coated balloon for ISR. In terms of this leave nothing behind approach, the idea is that if one of your major mechanisms of in-stent restenosis is from neointimal hyperplasia, if you're putting another layer of metal, you're going to increase more hyperplasia and reduce the amount of lumen that you have left, and it'll increase your chance of developing ISR. So the idea is that if you can effectively put anti-proliferative agents or drugs into that adventitia intima area without leaving a stent behind is ideal. In terms of leaving nothing behind, really the idea for this is anytime you put in a stent, you're always at risk of developing some sort of in-stent thrombosis. And in terms of ISR, that happens about 6 to 8% of cases. The idea is that if you don't put in anything that's left behind apart from this anti-proliferative agent, your risk of developing a thrombus in that area or developing late lumen loss is much lower. So that's the idea. And the idea is that if you have patients who have high bleeding risk, maybe a shorter duration of dual antiplatelet therapy may be beneficial for a drug-coated balloon as opposed to putting in a stent.
Yeah. Going back to the point of identifying what is exactly the issue with the stent is very important. And nowadays, despite that, a lot of, it's a class 1 indication to use IVUS and to use OCT, there's still limited use of these really important devices. And you really want to understand the mechanism of failure of a stent before you intervene. In other words, it might be just that the stent was underexpanded or there was so much calcium around it, and maybe a drug-coated balloon is not just going to help you because the mechanism of failure of the stent is just not that, right? So this goes that we have also in our issue a really specific paper about IVUS and intracardiac coronary imaging that I really want you guys to sort of review and read for all the reviewers and all the people who are watching us. And I would like to sort of ask you a question. Beyond ISR, where do you think DCBs would be helpful? Of course, we have limited literature in the United States, but more literature from Europe. So what are your thoughts about that?
Yeah, it's a great question. So there's actually a decade of research that's been done both in Europe and in Asia. Again, like I mentioned before, a lot of these off-label uses, what we call it, for de novo large vessel, small vessel, bifurcation lesions, and long lesions is where really Europe and Asia have been looking to see if drug-coated balloons have any effect. And the data shows that it's really non-inferior to drug-eluting stent for all three or four of these indications. But there is no superiority with drug-coated balloon in relation to drug-eluting stent in all four of these indications. But one thing that's really important to really emphasize is something kind of what Dr. Parwani mentioned about prehabbing somebody before elective surgery. You really need to prehab a lesion before you're going to implement a drug-coated balloon. Like you talked about using IVUS to really understand how large the vessel is, not just using your eyes angiographically to see what the size of the vessel is. And if you see that there's calcium, whether it's circumferential or deep or shallow calcium, really using your tools of calcium modification to prep the lesion prior to putting a drug-coated balloon is important, because you need to size these balloons 0.8 to 1 ratio of the balloon to the vessel. So it's really important. And a lot of these studies, especially in the small vessel de novo disease, looking at these trials, there's a lot of criticism on these lesions not being adequately pre-dilated before a drug-coated balloon was implemented. One particular study in 2020 is called the Piccoletto study. There was a post hoc analysis looking at all the data, and they found that 75% of these patients did not have pre-dilation before a drug-coated balloon was implemented. So there was significant late lumen loss there. And there was a discussion on why that was. And it really has to do with prehabbing these patients and these lesions before you implement a drug-coated balloon.
And which specific population do you think in the future, when we have an indication in the United States for de novo lesions, which specific population would benefit the most in terms of drug-coated balloon versus a DES? Because we have really good outcomes with DES on de novo lesions. So what are your thoughts about that?
I see it being predominantly used for bifurcation lesions, where you do provisional stenting on the main branch and then you do a drug-coated balloon to the side branch vessel. I also see this being used in small vessel disease. Any artery that's less than 2.5 or 2 millimeters, opening that lesion up with a drug-coated balloon is where I see this being really used. The last indication I do see this being used is in our high bleeding risk patients. So we know in 2025, our chest pain guidelines showed that you can have a short duration of dual antiplatelet therapy up to a month of dual antiplatelet therapy, and you can go to single antiplatelet for drug-eluting stents. But this data was actually seen for drug-coated balloons 8 years prior. So I think as more data comes, there'll be shorter duration of dual antiplatelet therapy for high bleeding risk patients who undergo drug-coated balloon as opposed to drug-eluting stent placement for CAD.
Those are great points. Thank you.
Great point. Yeah. So we cannot cover every single topic in the journal. This is a copy of the journal, so that those of you who are watching us go and enjoy reading more articles, or in depth, even the articles we have discussed, being able to look at them more in depth. But there are a few articles that we couldn't attach today, and I'd like to have one of you guys do a little of a brief summary. So, Joe, you introduced already the topic of the intravascular ultrasound. Anything else you want to say about that particular article that was written by, I believe, Dr. Shah and colleagues?
Yes, so there are a few articles that we didn't present. One of the main articles is the Intravascular Ultrasound Imaging Guide PCI, Evidence and Practical Implications. So this was written by Dr. Shah here from Houston Methodist. It's actually a very nice review on a step-by-step how to use it, and it also includes a lot about epidemiology, where we stand, what are the current guidelines and guidance, and the guidelines as well. Definitely very important to read, as as if someone is an interventional cardiology fellow or an interventionalist who has not been using imaging a lot. It would give you a lot of an overview on this disease, on the use of the device, as well as step by step on how to use it and size your stent in terms of sizing and in terms of length. So I would definitely encourage them to read it.
Another article that I found very interesting was this. The difference in invasive coronary physiology in the LAD. In fact, I learned a lot because, we are all in the impression that FFR is everything. You just go in, you check it. If it's bad, you put a stent, and if it's good, send the patient home. And apparently it's not quite that simple, right, Joe?
Yeah.
So you want to give a little summary of that article too, because I think that was a very instructive article.
I think what has been the norm is we think that LAD is similar to left circ, is similar to RCA, and this is completely not accurate, right? The LAD gives supply to a huge amount of myocardium, and you have to take that into consideration. So maybe the FFR cutoffs are not the same for the LAD. A mildly positive FFR might just be not significant for a specific patient. And Dr. Johnson actually goes into details and giving case scenarios and examples about focal disease versus long lesion disease. I would definitely want the readers to go over this article because it's very important.
Yeah, I think it is very important. I agree. I absolutely agree. And then we have an article on coronary artery anomalies, a review, which I thought also was a very nice educational article. And Nadim, you want to say anything about it?
Yes.
I mean, it was basically just a great way to go to an article and learn a little bit about all the different anomalies. And I thought that was very instructive.
When we think of CAD, we always think about atherosclerosis, and it's important to remember that there are different types of coronary artery anomalies that can give rise to symptoms, can have complications for the patients. And now as we do more and more CTAs looking at the coronaries, we're always getting these comments on the origin of a coronary artery and then what the implications would be on management. So this review really tackles the coronary artery anomalies, such as those with anomalous origin, fistulas, or aneurysms, in terms of symptoms, imaging studies, workup, and management. So it gives again, as we do more and more imaging of coronary arteries, anatomical imaging, we're encountering these more often, and it's important to know what the implications are in terms of management with new transcatheter techniques that have been developed to tackle some of those.
Yep, and another article that I thought is extremely educational, and I really would encourage you to also read, is the article on the genetic risk score. We all know that there is a genetic component to CAD, but there's not any single gene. In fact, it's a family of hundreds of genes. And now there is the new DNA technology to be able to cluster all those genes and be able to eventually find the group of patients that have really a high risk for developing CAD. I think this is going to be a real game changer when it becomes more available. And then now they're thinking even of how to apply that type of information into eventually development of a vaccine. So that's a very exciting article that I would encourage all of you to go and read, because it's very educational and obviously thinking of the future, which is going to be here, and many of you will see it. So at the time it's come to summarize, I think we've had a wonderful webcast. I want to really thank all the participants. Everybody have done a fantastic job. I want to invite the readers to please come to the journal and learn, as we all do, from all these wonderful reviews. In addition, you're welcome to send us cases for submission. There's no guarantee that they'll be accepted, but we would love to see them. And to just stay connected with us through the webcast and all of our other educational activities. Thank you all for participating.